because we don't have a whole lot of time to deal with stuff. What I like, because you probably put all of your energy into thinking about the test and preparing for that, I'd love to be able to give you the rest of the day to decompress, but we really can't do that. However, what we can do today is deal with a fairly light topic. What we're going to get into next is the musculature. And the chapter on the joints is a nice sort of transition.
This is AP2.
Oh, I forgot I was. I had the page all set up. I'm like, okay, I'll just start off, and I forgot that I went into ANP2 and changed something. Okay, so anyways, back to what is actually going on. So this is a nice transition chapter, kind of like the skin. The skin is really just a way for us to transition from dealing with the foundational material about chemistry and biology, cell biology and tissues, to actually dealing with organ systems. Here, this is a good way to kind of link the two halves of the semester, if you will. Obviously, you just took the first practical, which is kind of the halfway point of the semester. And so what we're going to be doing with the second half of the semester, like I said, we're going to get into the musculature. And then we'll look at the nervous system after that. Those together, the neuromuscular systems, are kind of their own thing. They're a different beast from what we've been doing so far. We're going to be dealing with a lot of cell physiology and electrical activity and molecular mechanisms that make it possible for muscles to contract and your nervous system to control that. So it's going to be on a kind of different plane. Really, over the course of all of ANP2, I would think that the neuromuscular portion, the second half of ANP1, is probably the toughest part of the whole course. Certainly, of the 4 practical exams that I give to an ANP1 and to an ANP2, the second practical exam is the toughest. Just sort of wrapping your mind around how muscles in the nervous system work, and putting it in the context of real-life case studies. So take that as a little warning as to what you're getting into for the rest of this course. But also, after you finish ANP1 and you finished the neuromuscular portion of the course, it's not exactly all downhill from there, like easy sailing, but it doesn't get worse than that. And really, part of what makes it so hard is that it's where we really get into the tough material, and it hardens you up a little bit. So when you get into that and you make it through that portion of the course, the rest of it will seem comparatively easier, even though really it's not. We're going to be dealing with the same sort of cellular physiology aspects, whether we're talking about how hormones work, or kidneys filter blood, or the heart beats or whatever. All of that stuff's the same kind of hard, but it's going to feel, hopefully, a little easier to deal with, because it's really just an extension of what we're going to be doing for the rest of this semester. So before we get there, the joints is a great place to kind of move into thinking about that stuff before we have to deal with any of that type, the tough material. Well, we can think about the, I don't know, kind of architectural, if you will, aspect of the body, the skeleton that we just dealt with. And granted, we went through it pretty quickly because of how the summer works. But we can start thinking about how that's going to be the basis for movement. And so this next chapter on joints and movement has sort of 2 components to it. one is what are the different joints, and two is how do we describe movement. So that's kind of what I want to do, what I want to talk about here. Now, really, it doesn't take that much work to go through this stuff, and so that's what we're going to do for the rest of the day. And we might wrap it up before noon, and we'll be able to get out of here early. Just whenever I say we might get out of class early, keep in mind that that does require me to not talk so much, and I'm not very good at that. But it really isn't that, I don't know, involved of material. So in the joints chapter, so we're in support and movement, joints, there are two things that we want to address. One is how we classify joints, which there's a section here specifically called that. And we look at the classification of joints based on their structure and on how they function. And then the chapter goes in to look at the three major classifications, which are only one of these two things, the structural classification. The functional classification is just some terms to know about, to understand what they're talking about. And then the chapter goes into the types of body movement. So it's really about what words do we use to describe movement. Bending your elbow is not a very precise way of describing that movement. So we have very specific terms for that, which you should expect by now in the anatomy course. That we need to have precise descriptors for things. I want to point out a little bit about some particular joints. So I'll do a little bit there at the end. The chapter then goes on to look at the development of joints, which we're not going to go into. If you're interested in reading that, you can, but I don't ask any questions out of that stuff in at least the part 3 and part 4 assignments. So again, the joints can be classified either by structure or by function. We'll deal with a functional classification first, just because we want to get those terms kind of out of the way. Now, it starts right here. We're going to talk about this first type in a second. But before we go there, let me just introduce the terms for you. So I'm about to describe for you the synarthrosis. And then after that, we'll look at amphiarthrosis. And then after that, arthrosis. So I'm telling you all three of these words together right now. They aren't on the same, they're not obvious for me to put up on the screen from the book. But I want to point out to you that all of them have at their root, arthro, I should spell that correctly, arthro, which is the root that means joint. You're probably familiar with that joint. You're probably familiar with that root. Its most common usage is in the term arthritis, which is swelling of the joints. So that's where that comes from. Now, the difference between these three words is really just what the prefix is. So syn, amphi, and di. What those prefixes mean in Greek tell us what types of joints those are. Okay, that's what it's about. So synarthroses, I should say this about the ending. To be consistent with the book, in the list I just wrote, I ended each of those words with cis, which again is just a reflection of the Greek word. It's just a noun ending for Greek words. The plural of a noun that ends in sis like this would be ses. So synarthrosis is a singular of this type of joint. Synarthroses are all of them collectively. Another way to use these words instead of the Greek noun form that we have here, instead of sis, if we end this word with tic, so synarthrotic, that's an adjective. So if we talk about synarthrotic joints, that's just another way of saying synarthrosis or synarthroses. And I'll go back and forth between both, just what's kind of comfortable for me to talk about. Just keep in mind you're paying attention to the synarthro part of the word. Okay, whatever ending I put on there isn't as important as understanding what the word means. So syn in this word means together. So synarthroses are joints that are together. And what that means is where two bones come together, which is what a joint is. Synarthroses are where the joint does not move whatsoever, or I should say the joint is held together fast. In this case, the most common example of our synarthrotic joint, the suture joints in the skull, the periosteum around one bone and the periosteum around the other bone basically intermingle to the point where you can't distinguish them. And it stitches everything together. Now, a bone and its periosteum in general are very closely associated. Collagen fibers in the bone tissue are going to be continuous with collagen fibers in the periosteum, linking them together very closely. If two bones and their associated periostea, whatever the plural that would be, come together, then the collagen fibers in one bone are going to be continuous with its own periosteum, which are going to be continuous with the periosteum of the other bone, which is going to be continuous with collagen in the next bone. So really, we have collagen fibers that are going from one bone directly into the other bones. They just all come together. And that's partly why they're called suture joints. It's like they're stitched together. They have fibrous proteins going from one bone directly into the other bone, holding them together. And so all of the joints in the skull, aside from the one between the jaw and the rest of the lower jaw and the rest of the skull, all the rest of the joints in the skull are sutures. They don't move, they hold fast. There are other examples of synarthroses. Another great one, which is actually in this picture too, is the joint between either the maxilla or the mandible, either jaw, with the teeth. That's another synarthrotic joint. Your teeth don't move in the jaw. They have their own special little name besides suture, but they're the same kind of idea. And teeth are kind of bones. Really, they're bones that just have an enamel coating on the outside, making them a little tougher. But deep down inside, they're really just bone tissue. So those are synarthroses. They don't. They're held together very tightly because they just have collagen fibers going from one bone directly into the other bone. They hold together. Amphiarthroses are well, amphi means partial. You're probably most familiar with this term, or this root, in two different terms. One would be amphitheater, and the other, actually, we'll go there in a second. Amphitheater or amphibian. Okay. So amphibians live partially in water and partially on land. Amphitheaters are partially covered theaters. Probably the most famous amphitheater that you've probably all seen, and you don't really realize it, is the Hollywood Bowl. The reason it's so popular is that being in Hollywood, it's a common place for movies to be filmed. So you've probably seen plenty of movies where there's a stage with a half shell covering, big white half dome covering the stage, and then all of the seating is open air. That's an amphitheater. And the Hollywood Bowl is often featured in movies. A recent one, if you saw the Jim Carrey movie Yes Man, it's the one that comes to mind right offhand. There's a scene where he and Zoe Deschanel, or whatever her name is, are running around the Hollywood Bowl. So you've probably seen that. And it's featured in a lot of other movies. But that's an amphitheater, a partially covered theater. I hesitated for a second as I was saying all that because I recalled I was listening to a radio show on the way into work today where they were mentioning a kind of funny headline mistake that I don't really follow baseball, so I don't know exactly what this is. I mean, I know what it is, but I don't know who this is, and I don't remember the name. But there's a pitcher currently in the major leagues who's unique and outstanding because he's ambidextrous, which means that he can pitch equally well with either hand. I don't remember the name of the pitcher because I don't follow baseball that closely. And the person who was mentioning it said that the last time that occurred was back, there's a pitcher in the mid-90s who was ambidextrous. So it's really a big thing for this to show up. And it's sort of once in 20 years that there's been a picture of that ability. But the reason they mentioned is because a paper telling the story of this in their headline said that the pitcher was amphibious. Which is kind of funny. But amphi as an amphiarthrosis or ambi as an ambidextrous are really the same root. They mean partial to some extent. And so amphiarthroses are joints that are partially movable. They're held together usually just by cartilage. And the picture that we have here in the book of an intervertebral disc is a great example of a amphiarthrotic joint. There's fibrocartilage between two vertebral bones, and when your vertebra move, the movement's actually taking place in a different location. I can kind of point that out here. There's a joint where this bone comes together with, I guess it's supposed to be right here the way it's drawn, where this bone comes together with this bone, except where they're drawing it isn't quite accurate. And that's where the actual movement between bones takes place, as far as the pivot, if you will, when you're bending your back. But when you do that, there's movement of one vertebral body relative to the next, and the joint between them, which is largely defined by that fibrocartilage pad there, is partially movable. And by partially movable, we mean barely movable at all. You can arch your back quite a bit, so yeah, they're gonna, the angle between two bones is gonna change a measurable amount, but it's not a whole lot. Another example of an amphiarthrotic joint, which is a better representation of the idea of partially or barely movable, is the pubic symphysis. Again, another fibrocartilage pad, which is not necessarily relevant. It doesn't have to be fibrocartilage, but it is just cartilage there. This joint does not move very much at all. Now, how you define how much it moves can vary a little bit by what kind of perspective you take. Across the entire human population, half of the human population does not move that joint at all. Which half do you think that would be? Men, right. That joint's only going to be used during childbirth. And since men don't bear children, they're not going to move that. But even if you just say we're only talking about that joint in women, for women it doesn't move very much either. Now, it doesn't move very much as far as the angle is concerned because the point is to open the birth canal a little bit wider, and so there's going to be a very modest angle change there so that the pelvic girdle is a little bit wider when it needs to be. But also it doesn't move very much because it's not used for a lot of a woman's lifetime. Now, I got yelled at, the worst I've ever gotten yelled at by a student once, by making the following statement. So let me make the statement and then explain what I mean by it. It's not, the movement of that joint does not represent a significant portion of a woman's life. I said that statement, I got yelled at. When I use significant in that context, I'm talking about it in terms of how much time in a woman's life that joint is moving. Okay. Apparently it was interpreted to mean emotional significance or something like that, and that's why I was yelled at. But no, that's not what I meant. Even if your last name is Duggar, you do not use that joint a lot. So if you don't get that reference, the Duggar family is rather infamous nowadays, but their claim to fame was that they were, they had a show on television called 19 and Counting. And Mrs. Duggar, well, the Duggars believed that be fruitful and multiply was not just something in the Bible, but it was a challenge. And so they had 19, they might even be working on their 20th child now. If I remember correctly, within that brood of children that she has, they're all single births except for maybe one pair of twins, maybe two, I can't remember. So what that means is there's at least 17 individual episodes of labor. Now, I don't think this is a very accurate representation, but the numbers are very easy to work with. So let's pretend on average, Mrs. Duggar spends 5 hours in labor with birth. Okay. Maybe the first one was a very long birth, labor. I'm sure by the end that they moved pretty quickly. But so let's say 17 times in her life, she spent on average 5 hours in labor. That's going to be 85 hours of her life or something like that. Okay. At the time that she had 19 children, she was 43 years old. Okay. So I'm not going to do the math, how many hours she'd been alive in 43 years, but 85 hours out of all of those hours in her 43 years of life is not a significant amount of time. Okay. So even for somebody that uses that joint a lot, it's not a whole lot of time. So it's amphiarthrosis is referring to very little movement. More in terms of how much the bones move relative to each other, but to some extent, especially with that pubic symphysis, how little it gets moved overall, or to say that how much time of anybody's life, and for men, it's 100% of that time, that it doesn't move at all. Another example, oh no, I don't want to go there. That comes up in a little bit. And then the third type is diarthrosis. Now really the prefix from Greek is dia. But since dia ends with an A and arthrosis, or arthro starts with an A, the A's kind of overlap. So it's diarthrosis. Usually when you see a word that starts with di, you think of that it means two. Okay? I actually can't think of any common words offhand that start with di, but because usually it's bi, like bicycle, bicycle or something like that. But there are some places where di is used and it means two, but that's actually a Latin use of that. In Greek, dia basically means through. And so diarthroses are joints that move through a wide range. So this illustrates a little bit better the idea of amphiarthrosis versus diarthrosis. Amphiarthrotic joints are only going to move a little bit, very small change in angle. For instance, diarthroses are going to make huge changes. They might be 90 degrees worth of movement. They might be even more. Probably the most movable joint in your body is your shoulder joint, and it can certainly move through a full circle. Okay. So these kind of joints really move. I want to talk about the specific types of diarthrotic joints. They're broken down into a little bit more detail. And we'll get to that in a second. What I want to do is actually back up here and just point out the structural classification a little bit. I actually have kind of already pointed this out with one major exception. We can also classify joints based on what they're made out of. So there are fibrous joints. Oh, and actually let me add this to the list here. And I'm going to put it here. So there are fibrous joints, there are cartilaginous joints, and synovial joints. So these two lists look like they kind of match up perfectly. When I talked about the synarthrotic joints, I talked about how they're basically held together by fibrous proteins like collagen. And then the amphiarthrotic joints that I mentioned are ones that have cartilage, usually fiber cartilage between them. And I'll talk about what synovial means in a second. But fibrous and synarthrotic are not perfectly aligned. There are synarthrotic joints that are not that are not fibrous. And there are cartilaginous joints that are not amphiarthrotic. What it is that there are some examples of cartilaginous joints that are synarthrotic, that don't move. And there are examples of fibrous joints that do move just a little bit. Okay, so there's a little bit of overlap between the first two entries in either of these lists, which is not something to worry about because we're actually going to concentrate most on the last examples in both synovial / diarthrosis, and those always correspond. Synovial joints are always diarthrotic. Diarthrotic joints are always synovial. But the other two, there's a little bit of gray area there. For example, there's a cartilaginous joint that's synarthrotic in our rib cage. There's cartilage between each pair of ribs in the sternum. The first pair of ribs in the sternum, while they have cartilage between them and therefore are cartilaginous, don't actually move. The sternum and the first pair of ribs act as a single unit. When you breathe, for example, you expand your rib cage, your chest, your thoracic cavity to get air to come into your lungs. And the way that happens is really that, and this kind of doesn't work that well in the summer, those ribs and the sternum work as one piece. And the reason why I say that doesn't work very well in the summer, I usually demonstrate that because I'm usually wearing a tie. And I could show you that the tie is sort of one big piece. It's all one. So the first pair of ribs is kind of the part of the tie that goes around my neck, and then the sternum is like the knot down to the point of the tie. All of that moves as one piece, even though there's cartilage between the ribs and the sternum. That joint doesn't move. The movement occurs where the ribs meet with the vertebral column in the back and where all the other ribs meet up with the sternum. That's where the movement is. But first pair of ribs to the sternum don't really move. So it's cartilaginous, but it's synarthrotic. And then there are fibrous joints that can be amphiarthrotic, which would be when we have a ligament between two bones that might be a little bit loose. I don't have a great example of this, but I think in the leg where the tibia and the fibula come together, the distal joint between those, which is basically at the ankle, there's no movement. Okay? There's a ligament there and it's synarthrotic. It's fibrous synarthrotic joint, which you need because the tibia and the fibula go around the talus of the foot so that the ankle joint's nice and secure. But the proximal tibia-fibular joint is probably a little bit looser. There are some situations where the tibia and the fibula move relative to each other at that joint because the fibrous ligament might be a little bit loose. I'm saying that with some qualification because I'm not entirely sure exactly what's going on at that joint. I basically don't care too much about the fibula. It's in one of the cases that you just dealt with because it's part of that case. But honestly, I don't, other than to know that it's that thin, long bone on the lateral side of your leg, I don't know that much about it. I can't actually place it accurately on the right or left side if I look in one. I don't know what the two look like. So I don't really care about the fibula. So I don't really know too much about the proximal tibio-fibular joint. But it is a fibrous joint, and there might be some movement at that joint, having to do with how the knee works. So that's possible. But the fact that fibrous and cartilaginous joints don't 100% match up with synarthrotic and amphiarthrotic joints. Doesn't really matter because we're not going to deal with those joints anymore, okay? Other than to know that they exist. And when I'm talking about breathing at A&P2, we'll get back to the sternum, rib joint things later on. But what we are interested in are the synovial or diarthrotic joints. And those are 100% correspondence. Like I said, synovial joints are always diarthrotic. Diarthrotic joints are always synovial. There's no exceptions to that. And that's because diarthrotic joints, ones that move quite a bit, need the structure of a synovial joint. So we'll keep that in mind. Now, I think actually in the book, they don't have a picture of the synovial joint in this chapter. Oh, maybe they do, sorry. Yeah, I was thinking this was in a different chapter. But so here we have the end of one bone and the end of the adjacent bone, and they're making a joint. There's a joint capsule, which is mostly ligaments that are attaching one bone to the other. Sometimes joint capsules can be a little bit more complex than just plain ligaments, but it's the dense connective tissue that's holding the two bones together. The end of either bone is covered in the articular cartilage, which is a hyaline cartilage pad, really just remnants of the cartilage that was part of this bone originally that never fully calcified. And the reason it's there is it acts as a little buffer, a little cushion there. Okay. The cartilage that's on the outside of on the end of the bone here is going to fuse directly into the periosteum of the bone, which is going to become part of the joint capsule, and then the joint capsule connects the periosteum over here, which is continuous with the hyaline cartilage of the articular cartilage here, and then it just goes back through here. So really there's several different types of connective tissue here, but they're all one continuous piece of cartilage. Synovial joints are defined by this cavity that's outlined by these tissues that all fuse together. So it's an enclosed space. It's filled with a fluid called synovial fluid, which acts as a lubricant at the joint because the joint's going to move. Now, the synovial fluid is made by what's called the synovial membrane, which is represented by reddish color on the inside surface of the joint capsule. So on the inside surface of the joint capsule, some of that connective tissue is very loose connective tissue as opposed to the dense connective tissue you'd expect there, but loose because it has a lot of blood vessels. And there are specialized cells that are part of that tissue that help to absorb things out of the blood and secrete the fluid into that space. There's no epithelium in there. And epithelia is what we expect would absorb and secrete things, but it happens to be specialized connective tissue cells there that make this fluid. And that fluid, again, acts there. That's what synovial joints are about. And any joint that's going to move enough to be called diarthrotic has to have synovial fluid as a friction reducing medium. So they're always going to be synovial. Now this is a pretty standard picture to represent a synovial joint. And what it's supposed to represent is the joint of one of your knuckles. Okay, so the two bones that we see here, two phalanges coming together, and then there's a joint capsule around it. The synovial joints that you see there don't actually look like that. They always exaggerate the synovial capsule and the space filled with the fluid for the sake of this kind of picture. But if you had that much fluid between the two bones and one of your knuckles, you would see a visible bulge around it. When do you tend to see that kind of visible bulge around a knuckle? What do you call it? Yeah, that's what arthritis is. So arthritis is just the accumulation of fluid in joints, and so if there's so much fluid at the joint that it bulges out, it's going to look like that. So that's not really what they look like normally, but for the sake of the textbook to show you the components, they're putting that much fluid in there, but there would not be that much fluid. Really, the joint capsule would kind of be collapsed in on either side. The hyaline cartilage on either bone would pretty much be touching. The normal rubbery consistency of any cartilage wouldn't be seen here so much because it would have a lot of the synovial fluid kind of soaked into it. So it'd be a little bit more pillowy. Again, that helps to protect the bones there. When people start to have problems with joints, sometimes it's because that cartilage gets damaged. When you lose that cartilage and you start to get bone tissue from one bone rubbing directly on bone tissue from the other bone, it can be quite unpleasant. So those are synovial joints. Now, this is a picture of the knee joint, which is an unusual synovial joint in that it's not actually a closed synovial joint. If you've ever heard somebody refer to water on the knee, what that actually is referring to is the synovial fluid from the knee joint can leak out and get into some of the spaces surrounding the knee joint, and it can cause problems. And that's just because the knee joint's kind of a weird joint. It's not actually a closed synovial joint. But in this picture, besides the fact that you can actually kind of see that there's a little bit of an opening to the joint here, they also point out some features that you see at synovial joints that I want to make mention of. The most important of which are called bursae. Bursa is singular, bursae is plural. These are like little synovial fluid capsules that are not actually at the joint, but rather wrapped around other features, usually tendons. So in this picture, they're pointing to a bursa that helps to lubricate movement of the patella against soft tissue on the outside, so muscle and whatnot that's beyond the knee joint. And then here's one at the proximal head of the tibia that helps with where the attachment point from the tendon, which is really coming from the muscle going across the patella and attaching there, where that might rub against the head of the tibia. So there's a little bursa right there. There are bursae at the shoulder joint. There's two major ones. One somewhere right around in here where the rotator cuff tissue can move relative to the head of the humerus. And then another one that wraps around the tendon of the biceps, which goes past the shoulder joint where it attaches. So there's bursa at a number of different places, and they're just using the knee joint to point that out. But there are a few others. I'm going to talk about some of the other structures of the knee joint later on using a different part of the book, but they're kind of pointing them out here. Now, synovial joints come in a few different types, and this picture demonstrates that. Let me just open this picture up. There are 6 different types of synovial joints. And why did it just do, oh, there we go. Hold on a second. Computer's being funny. There we go. So there are 6 different types of synovial joints that are listed here. We could just as easily say that there are 6 types of diarthrotic joints, but we usually think of them in terms of the structural classification, because these are structural classifications. So let me list these real quick under synovial. I'm going to start with the planar joint. I'm too lazy to put indentions here because I just have to put in spaces, but I'm going to shift from numbers to letters just to show that these are types of synovial joints. Then I'm going to show you the hinge joint, then the condyloid joint, then oh shoot, I missed one. The pivot joint, then the hinge joint, then the convoy joint, then the saddle joint, and finally the ball and socket. So, okay, I'm not that lazy to put them in. These are the types of synovial joints. So putting them under there. I'm writing them out here because I want to go through them in this order. And I'll go back to the picture in a second to show them to you. In the picture, just in any picture that's going to show this, is going to usually put them in an order that works better with how they're laying out the picture. But I'd rather go through them in this order for a couple of important reasons. One is another way to think about these types of synovial joints is also to think about how many ways can each joint move. And the planar joint is able to move in all sorts of different directions, but it's moving across a two-dimensional surface, a plane, hence the planar joint. Those are special kind of movements. All of the other joints move around axes, but planar joints are two surfaces sliding across each other. Now in the picture here, they're pointed out at the ankle. The common place to show this type of joint is either the ankle or the wrist. That's mainly where we see them. And they're not using the wrist in this picture because the wrist is kind of already obscured by a couple of other examples. But the carpal bones in the wrist or the tarsal bones in the ankle, when they move relative to each other, they move as planar surfaces of the joints sliding across each other. It's really hard to actually demonstrate that movement. You can't isolate that movement out from other things. So the best way that it's usually demonstrated is if somebody's going to wave their hand like this, side to side, then the carpal bones in the wrist are moving like this relative to each other, but other movements are taking place at the same time. I can't isolate it out, but that's what's happening. The same kinds of movements are going to be taking place in your foot while you're walking, but again, there's a bunch of other things happening in your foot while you're walking too. So it's not something we can isolate out, but the idea is just when two flat surfaces move across each other, those are planar joints. And the majority of examples of that are, again, in the carpal or tarsal bones, where they make joints with each other, what we would call carpal or intertarsal joints, joints between those bones. All of the rest of these are described based on axes of movement, which is to say if we drew a line through a joint. Okay, so I'm going to take this thing here. Let's pretend we draw a line through my elbow joint in this direction. Can't actually insert this through my elbow, but imagine we're drawing a line like that. The elbow moves around that line. That's an axis of movement. So the first one I want to describe to you is the hinge joint, and the perfect example of a hinge joint is the elbow. When I was talking about the special structures on the humerus and the femur last week, I talked about the hinge-like movement at the elbow, and that's because it is a hinge. The olecranon of the ulna moves around the scrollwork distal end of the humerus a lot like the pin structure of a door hinge like we have over here. And it's moving around one axis. We cannot move our elbow in any other direction. And we call that a uniaxial joint, one axis of movement. I've seen a few sources recently that will refer to that as a monoaxial joint, and I want to warn you now that that's an abomination unto the Lord. Uni and axis are both Latin word parts. mono is Greek. Okay. So when you're making formal terms for science and that sort of thing, you don't mix Greek and Latin things. So it's a uniaxial joint. If you see it referred to as monoaxial, it's just not the proper use of language. The hinge joint's a great example of that. The other type of uniaxial joint is the pivot joint, and the perfect example of that is in your neck, where the first two cervical bones come together. So C1 and C2. C2 has a little piece of bone sticking up, which is the axis of rotation, and C1 wraps around that axis. And so C1 rotates, pivots around that. That's what makes it possible for you to move your head like this. Okay. And in fact, C2, that bone, is called axis because it's the axis of rotation for that particular movement. And it has a piece of bone that makes that possible. So it's a perfect example of that. Those are the two examples of uniaxial joints. The next type of joint based on axes of movement would be a biaxial joint. And that's where we could draw two lines across the joint, and it's going to move around both those axes. So for instance, with the joint between the proximal phalanx of my second digit in my hand, and it's the second metacarpal bone. Okay, so this joint right here. If I draw a line through it from this direction, I can wag my finger like that, or bend my finger like that. If I rotate that line 90 degrees and go this direction, then this is the word wagging finger that comes from. So you can do that. That's biaxial. We can move it in two directions. And the type of joint that we're talking about here, which is the phalangeal metacarpal joint, is a condyloid joint. When you're looking at the names of parts of bones, bone markings, a lot of bones have things called condyles on them. Anywhere that we have a condyle on a bone, it's probably part of a condyloid joint. Because it allows for those two types of movement. Now, the thing about a condyloid joint is that one direction is always going to be more movable than the other. So you can bend your finger one direction a lot more than you can bend it the other direction. Another example of a condyloid joint, which is a good place to demonstrate this idea of a little movement in one direction, a lot of movement in the other, is the first cervical bone and the occipital bone. So in this vertebral column model that I point to a lot, this is the occipital bone here, part of the skull. And the top of the cervical spinal column here, where those two come together, that's a condyloid joint. And the occipital bone has two structures called the occipital condyles, which make that joint. They can move in this direction pretty easily, which is actually what gives us the ability to bend our neck this way or our head this way to nod yes. It also can move a little bit side to side. Now, it's really hard to demonstrate that because when you move your head side to side, you're actually using the rest of your cervical bones. But if you can keep your neck completely still, you can still move your head side to side just a little bit. That's movement at that time of the joint there. When I talk about the knee, that's also a condyloid joint. I'll explain how that moves in two directions also. But there's always going to be a little bit of movement in one direction, a lot of movement in the other, because it's a fairly asymmetrical joint. Now you can make those two movements happen at the same time. So we can bend our finger this way and we bend our finger this way. You do it at the same time, you sort of do the whoop-de-doo kind of movement with your finger. Which is a special type of movement, which I'll talk about in a little bit. Now the other type of biaxial joint that has two axes of movement is called the saddle joint. Now, there's only one joint in your whole body that's the saddle joint. Now, really, there's two because you have one on the right and one on the left. But it's the joint between the metatarsal of your first digit in your hand and the carpal bone adjacent to it, this joint right here. You can move it in one direction like this pretty well, and you can move it in another direction like this pretty well. So it's like a condyloid joint. It can move in two directions, but what's different is that both directions have pretty good range of movement. Really, a saddle joint is kind of a modified condyloid joint to have more movement in that direction. We only have it here, what's essentially the base of the thumb, because that gives us the ability to move our thumb across our hand to reach to our other fingers. Gives us the ability to oppose our thumb to our other fingers, which is an important movement. Now, it gives humans the ability to hold tools. Okay, so I can pick up this marker because I have the ability to oppose my thumb, and I can wrap my hand around it. Other primates have that ability too. Monkeys, for instance, have to hold on to branches when they're swinging around, or chimpanzees or something like that. I've not been able to find a definitive source that tells me if other primates have saddle joints also, or if it's unique to humans. Other primates can hold their hands in such a way that's like opposing their thumb, but the hand's a bit different. So like I have been able to find some descriptions of a chimpanzee's hand's anatomy, and the thumb is in a very different location. It's not so close to the other fingers. Chimpanzees' metatarsals are a lot longer and its carpals are much bigger. So its thumb is quite a bit further down, and so opposing its thumb to its other fingers might not be based on a saddle joint. It might be more based on how all of the joints between the fingers work together. Whether it does or not isn't terribly important. This is a human anatomy and physiology course, but just I like to talk a little bit about other species when it's relevant. So this might actually be something that only humans have, but it might be something that other primates or maybe even raccoons have or something like that. And it gives us the ability to oppose our thumb and grasp things. So I've shown you all but one joint. Okay, so the planar joint, which is two surfaces moving across each other in two dimensions, and then the uniaxial joints, which are the hinge and pivot joints, and the biaxial joints, which are the saddle and condyloid joints, or I should say condyloid and saddle joints, in the order I did it. And that leaves us with the ball and socket joint. And what's special about this is that it's not uniaxial, it's not biaxial, it's actually triaxial, but for some weird historical reason that I'm not entirely clear on, it's referred to as a multi-axial joint. It's almost as if anatomists can't count past two. It's like, okay, one axis of movement, two axes of movement, too many axes to number. Okay? There's only three. There's no 4 axes or 5 axes or anything like that. It's only 1, 2, or 3, but for some reason, the joint that has 3 axes of movement is most commonly called a multi-axial joint. Okay? And the ball and socket joint is found in just 2 major locations. And again, there's a right and a left of each. So there's 4 ball and socket joints in your body. The one that's pointed to in the picture is the hip joint. And that's a great example because the socket of the hip joint is very obvious in the pelvic bone. It's a big round socket here, and the head of the femur fits right into it. The other one is your shoulder. The shoulder's a little bit harder to demonstrate looking at a skeleton because a lot of what makes up the socket of the shoulder joint is soft tissue, what we call the rotator cuff. But they're both capable of making these kinds of movements. So you can move your shoulder joint around quite a bit. You can move the hip joint around quite a bit too, not quite as much because the difference between the bony socket of the hip and the soft tissue socket of the shoulder, but they both are ball and socket joints. So those are the different types of synovial joints. And again, they're all diarthrotic. They all are highly movable. How much they move depends on which classification we put them in, but they all move quite a bit more than amphiarthrotic or, well, of course, synarthrotics that don't move at all. But when we're talking about movement, it's synovial joints, and they move that much because of the lubrication of the synovial capsule. So that's classification of the joints. The other thing to talk about today is movement terms. And so in the book, they have a section that's type of body movements, and it's just naming all of them. I want to go through these in usually pairs. So I said earlier, bending the elbow is not a very accurate way of describing what's going on. So instead, we have to use more precise terminology. And for the elbow, we use flexion and extension. Flexion of the elbow would be bending it in the anterior plane. And when I describe it that way, think about anatomical position. The anatomical position, I'm standing in front of you like this. So if I flex the elbows, my forearms are both moving anteriorly. If I extend, then they're both moving back to the anatomical position. So either of those we could potentially say are bending the elbow, but specifically one movement is flexion, the other movement is extension. We can do that at other joints too, so I can flex at my elbow and I can extend at my elbow. I can flex at my hip and I can extend at my hip. I can flex my spine, I can extend my spine. Really, extension should describe movements back to anatomical position. And for the elbow, that's all the movement can do. Flex anteriorly or extend posteriorly back to the anatomical position. You can't move the elbow joint any further than that. But for the other joints, they can move a bit more. So we can have flexion and extension, but there's also movement in the posterior direction beyond the anatomical position. More accurately, that should be called hyperextension, okay, just to be as accurate with the terms. However, if you look up a definition for hyperextension, you'll usually get reference to that being associated with injury. Okay. If you hyperextend your elbow, yeah, you're breaking something because it's not supposed to bend. Some people might be able to hyperextend a little bit past 180 degrees. Might be a little bit of a bend here, but to really get your elbow to bend all the way back, you have to break some bone. But other joints can move in more than just 90 degrees or so, whatever. So more appropriately, moving beyond anatomical position should be called hyperextension. But a lot of sources won't include that term. And in fact, in the book right here, it says hyperextension is the abnormal excessive extension of a joint beyond its normal range of motion. Okay. Which suggests that it's abnormal. But the most anatomical sense of the word, all of this is going to be relative to anatomical position. So hyperextension is really moving past anatomical position. And the book's not approaching that. A lot of places don't, because pure anatomical terminology is a little old-fashioned, but it is a more appropriate way of describing it. Generally, flexion is anything from anatomical position going anteriorly, so I'm flexing my fingers, any of these movements in my fingers, isolated is going to be an anterior movement. And then extension is going to go back out. And again, hyperextension, you might be able to get a little bit in your fingers, but not a whole lot, and certainly not at your knuckles. The one really weird example, exception to this is at the knee. When you flex your knee, it's actually moving posteriorly from anatomical position, and then extending your knee is bringing it back. Knees are just kind of backwards for that, as far as this is concerned. Okay. If you think of the knee and the elbow as being analogous joints, they're oriented opposite of each other. Okay. Your elbows go this direction, your knees go that direction. And it's just a weird thing about knees. It's sort of like the leg is kind of rotated around relative to the arms. The next set of words are abduction and adduction. While flexion and extension are anterior posterior movements, abduction and adduction are medial lateral movements. So if you're going to abduct your arms, you're going to go out to the side. Adducting, you're going to come back in. The easy way to remember those is abduct, abduction, is away from the body. So when you abduct your arm, you're moving it away from the body. Adduction is coming back from the body. At uniaxial joints, you're probably only going to have flexion and extension. I can't say that with any certainty because I haven't gone through all the examples. Not that there's a lot, but definitely the elbow can flex and extend, but cannot abduct or adduct. A weird case of abduction and adduction, which isn't actually a joint, has to do with the eyes. The eyes are rotating within the orbits. They're not moving relative to the skeleton, but rather within the skeleton. When you abduct an eye, you're looking off to the side. So you're looking away from midline. And when you adduct an eye, you look across midline. As I demonstrated that, I had to close the other eye. Why did I have to do that?
You can't go in different directions.
If one eye is abducting, the other eye is adducting. So if I'm trying to stress those two words, I can only demonstrate it with one eye open. You can't make both eyes abduct at the same time. You can, however, make both eyes adduct at the same time. As you look at things that are closer and closer to your face, your eyes actually converge a little bit. So there is a little bit of dual adduction, but not dual abduction of the eyes. When one eye abducts, the other eye has to adduct. Circumduction is the formal term for when we put those movements together. So I was talking about condyloid joints, that we can move in one direction and we can move in another direction. We put them together, we make the kind of work you do moving with our finger. That's called circumduction. Now the word circumduction literally means to carry through a circle or to draw a circle. Okay. So it's easiest demonstrated with the elbow. I can flex and not the elbow, with the shoulder. I can flex and extend with the shoulder, and I can abduct and adduct with the shoulder. If I do both together, I'm drawing a circle. That's what circumduction means. That's different from rotation. Rotation is also a circular movement, so to speak, but it's a movement around an axis. Okay, circumduction is abduction, adduction, and flexion, extension all together. Rotation is when you're actually moving around a single axis, like shaking your head now. You can rotate at the shoulder also, and that's a great place to show the difference between circumduction and rotation. So this is circumduction at the elbow. It's flexion, extension, abduction, and adduction all together. But I can also rotate at the shoulder by doing this. An easy way to demonstrate rotation at the shoulder or hip is to actually bend the limb. So as I'm rotating my arm, you can see my forearm going back and forth. Rotation on midline is just called rotation, but rotation off midline, we refer to it as medial or lateral rotation. So bending my arm, flexing my elbow, while I do this, medially rotating at the shoulder is when I bring my arm across my body. Laterally rotating is when I move my arm off to the side. You can do the same thing with the knee, because the knee bends backwards, it's a little weird. Medial rotation is when your foot goes off to the side. And that's because the knee is bending the opposite way of the elbow. And then lateral rotation is when your lower leg comes across your body. So it's really just medial versus lateral rotation at the joint. Then we have some special terms that have to do with very particular joints. Supination or supination and pronation are referring specifically to movements of the forearm. So in anatomical position, your palms are facing forward. So we just put our palms face up like this, flexing at the elbow. That's the supinated position or supinated position. Pronation is flipping your palms over the other way. And then supination as a movement is flipping back. So that's pronation, supination. What's happening is movement is taking place at the radial ulnar joint proximally and distally. So there's a joint here and there's a joint here that are both moving. Really, those two bones in your forearm are crossing over. So in the supinated position, or in an anatomical position, the two bones are parallel to each other. When you pronate your forearm, flip your hand over, now the radius and the ulna cross over. So let me think about this. Normally, the radius is lateral, the ulna is medial. Okay. That's going to stay the same when you flip your forearm over. Radius is still on the lateral position, and the medial position is ulna at the proximal joint, at the elbow. But at the distal joint, at the wrist, now the radius is medial and the ulna is lateral because they've crossed over. So anatomical position, they're parallel, pronated, they're crossed over. And actually, we have a great model to represent that. So here we have a model that I can show you the elbow joint flexing and extending, but also I can take the radius, which is the lateral, and ulna, which is medial, and rotate them relative to each other. Now the radius is still lateral here, but then it crosses over and ends up in the medial position of the wrist. So really what's happening here, this is what my arm looks like normally, and when I pronate down like that, and that's what the bones in my arm look like. So that's a really nice demonstration of that particular movement. The words supination or supination and pronation come from the words supine and prone, which are two terms that we use to describe how people are laying down. When you're supine, you're laying down on your back. When you're prone, you're laying down on your stomach. Okay. So if you think of somebody in anatomical position, when they're supine, laying down on their back, their palms are facing up. When you're prone, laying down on your stomach, your palms are facing down. Okay, so if we just talk about the forearms, palms up is supine, palms down is prone. I had a student several years ago that in another class was studying these words, and her instructor said a great way to remember this, and this is why I keep saying supination or supination, is if you can hold a bowl of soup, your hands are supinated. If you can't hold the bowl of soup, then you're prone. That helps you remember. Now the next pair of words here, dorsiflexion and plantar flexion, obviously are both examples of flexion, but what's special about them is that we're describing the foot. The foot's kind of weird because there's a whole lot going on with it. And plantar flexion is when you point your toes out. Dorsiflexion is when you sort of point your toes up towards your superior position in your body. Now, really, if we think about just the ankle joint, we're extending the ankle or we are flexing the ankle. That's what you can say. But really, there's a few different movements going on. So plantar flexion and dorsiflexion. Flexion basically means when the angle of the joint is getting to be less. So if we're flexing the elbow, the angle, which is basically 180 degrees to begin with, gets smaller. And when we're extending, the angle gets larger. So if you think about the foot, plantar means the bottom of the foot. So with plantar flexion, the bottom of the foot's getting to be a narrower angle. Dorsi is talking about the top of the foot, the dorsal surface of the foot. And so the dorsal surface is getting to be a smaller angle. That's where the term's going to come from. Inversion and eversion are also referring to the foot. Inversion is when you roll your foot medially, and eversion is when you roll it laterally. So from this position, inverting the foot is sort of like you're walking on the outside edge of your foot. Everting the foot is rolling it out, so you're walking on the inside edge. If you go to buy shoes, for instance, and this is the first time I'd ever heard this use of these terms, you'll hear reference to pronating and supinating the feet. Anatomically, it is completely inaccurate to say anything about pronating or supinating the feet. That's just not what those terms mean. But they're used that way, especially when you're talking about buying shoes, because when you're doing one, you're wearing down the sole, the inner sole of your foot, shoe. When you're doing the other, you're wearing down the outer sole. So depending on how you walk or run, often when you're buying running shoes, you think about this. You want to buy particular types of shoes because they're going to have more support where it's appropriate for your foot. They use pronation and supination to describe that, although it's not really an accurate use of those terms. It's more accurate to say invert or evert. I was talking with a podiatrist once about this, and I said, I teach anatomy, I want to find out why this is. Why would anybody say pronate and supinate a foot? She's like, oh yeah, because that's what you're doing. I said, but that's not what those words mean. Pronate is palms down, supinate is palms up, not about the feet. It's not about being prone or supine. So she sat for a little bit and thought about it, and what they call pronate and supinate, podiatrists or shoe salesmen, are really describing multiple movements in the foot. And she told me what all of them were, and I didn't commit them to memory. But for our sake, it's just really about inversion and eversion. But there's a little bit more movement that they're describing when they talk about the feet doing those. And we don't care about that. We're not selling shoes in this class. So if you hear supination and pronation referring to the foot, ignore it. It doesn't have anything to do with our class. This is just referring to the forearm position. The next two pairs of words, protraction, retraction, depression, and elevation, are usually described in reference to the jaw, to the mandible. When you protract, you move forward, so it's like getting an underbite. When you retract, you move back, so it's like getting an overbite. Depression of the jaw would be to lower the mandible or open your mouth. And elevation is to raise the mandible or close your mouth. So when you're chewing, you're depressing and elevating the mandible to bring the teeth together and apart. Protraction or retraction, you don't do it too much when you're chewing, but you can grind food between your molars when you do that to a little degree. Excursion is what you call the movement. There's a side-to-side movement of the mandible. Okay. Lateral is when you're moving away from midline. Medial is when you're coming back. Now, aside from excursion, those other four terms, protraction, retraction, depression, elevation, can be used in other situations, not just for the jaw. You can elevate your scapulae, your shoulder blades. You can depress your shoulder blades. You can protract your shoulder blades. You can retract your shoulder blades. So those can apply to other situations, but excursion, as far as I know, is only referring to the jaw because the jaw can just do so many different things. And then here they're talking about, so I just talked about sort of shrugging up. You can sort of combine those movements and your shoulder blades can move a bit more. And so there's some rotation. because of how it's moving relative to the shoulder joint there. Opposition and reposition are talking about the thumb. So I said we can oppose our thumbs, which means that we can touch the tip of our thumb to the tip of other fingers. And then reposition is just the opposite. So if I'm opposing my thumb to my pinky to make the Boy Scout salute, I can repose and bring it back to an open palm. Okay. So those are the words that describe movements. So I wanted to run through those and give you those examples so you can think about what they mean. The book goes through to describe them in some more detail, but there's a pretty good run through of them. Next week, when we're talking about muscles, we're going to be considering how muscles move. So we want to use these formal terms to describe those movements. Okay. So when we're talking about the muscles around the elbow, for instance, certain muscles are going to flex the elbow and other muscles are going to extend the elbow. So we got to think about those terms. They all bend the elbow to some degree. It just depends on which direction we're talking about that movement. Now, I also want to take a second to go to the anatomy of selective synovial joints. The book goes through a number of interesting joints, some of which I've already kind of mentioned. Here's the joint between the first two cervical bones. So this little thing in the middle is the axis of C2, which C1 rotates around, which we see. There's a ligament that kind of anchors it in place, and those two rotate relative to each other. The temporomandibular joint, I haven't talked about that joint specifically other than mentioning that it's the one joint in the skull that's not a suture. But all those terms I just ended with that have to do with the jaw, so excursion, protraction, retraction, elevation, depression, all of those are movements of the jaw, and those movements are taking place at this joint. Now, this is an interesting joint. It's sometimes referred to as a modified hinge joint. So it's a hinge. The depression elevation is really a hinge-like movement. But then it has additional synovial cavities in it, giving it the ability to move in other directions. It does a whole bunch of stuff. I've talked a little bit about the shoulder. I mentioned the bursae. There's one up here that helps to protect movement of soft tissue across the acromion and the scapula. And then there's another one wrapped around the tendon of the biceps, which would be right about here. The elbow joint, I don't really deal with talking too much about that, but there's some bursae and that sort of thing associated with that. And I talked about the hip joint, how the head of the femur fits into the very bony socket in the pelvic bone. I want to say a few things about the knee joint, however. Clinically speaking, there are some things about the knee joint that are worth mentioning. So this is kind of like the picture that I showed you earlier in the book to introduce the idea of what a bursa is. So there's more of that. Now, in these pictures, I don't want you to go, oh, I got to learn all this stuff. I just want to point a few things out to you. First off, the fibrocartilage pads between the femur and the tibia, which are in the knee joint, are very important. And we can see them here. So we're looking down on the proximal head of the tibia in this picture. So that fibrocartilage is laid out on top of it. It's called the meniscus. There's the medial meniscus and the lateral meniscus. So there's two pieces in those two relative positions on the tibia. Now, you can kind of see the way that's drawn, the two menisci, which I think is a plural of meniscus, make these little pockets. And the distal head of the femur that's going to fit on top of that has these two rounded scroll-like things, one that fits into each of those pockets. Those are called condyles. Okay? because the knee is actually a condyloid joint. I'll talk about that a bit more in a second, but we can see where that kind of fits in that position. When the menisci fail to do their job properly, when they lose their fibrous capsule enclosure and they tear something like that, then the body weight that's bearing down on your knee joint is going to cause the bone of the femur and the bone of the tibia to actually come into contact. And when you're moving your knee, it's a very painful thing to have happen. A lot of people that have knee pain have it because that fiber cartilage is broken down. I think I read 5 or 7 years ago now that UConn Farmington, the medical center that has to do with the University of Connecticut, they have a really good sports orthopedics department. And I think I read that they developed a way to rebuild the menisci in the knee following injury to that, or something like that. That's somebody doing research there is interested in that particular stuff. And I think that they had a way of rebuilding sort of synthetic meniscus to go in there. The other thing that we can see in this picture that I want to point out are what are called the cruciate ligaments. So there's the anterior cruciate ligament and the posterior cruciate ligament. Now in this picture, it's not quite obvious why they're called that, but cruciate refers to things crossing over. Crux is referring to kind of the shape of an X. The anterior and posterior cruciate ligaments cross over each other, sort of. They don't really come that close together, but if we were to look across the knee without all of the stuff in the way and just seeing the cruciate ligaments, we'd see one's crossing over the other. So in this bottom picture, we can't see it because they have the patella and the other tendons in here. But if all of this was out of the way and we could just see inside the knee joint, we'd see the anterior cruciate ligament going from the medial to the lateral position, from the medial tibia to the lateral femur, and then the posterior going from essentially the lateral femur to the medial, essentially the lateral tibia to the medial femur. Okay, so they cross over. So for my right knee, if we could see those cruciate ligaments, they look like this. The anterior one going from the medial tibia to the lateral femur, and the posterior one going from the lateral tibia to the medial femur. Okay. Not perfectly. The posterior one really seems to kind of come off the midpoint, but that's essentially the idea. These ligaments are linking those two bones together and providing support in that direction. Now the elbow is a hinge joint, and it's a very bony hinge. You can't really move the elbow side to side because the bone just won't allow that. The knee, however, is a condyloid joint. So it's mainly able to move in one direction, which is the hinge-like movement that we're used to thinking of. But actually the knee can move a little bit side to side also. Nobody that I'm familiar with has the muscular control to actually move their knees side to side. That's not the point of that movement, but rather it provides a little protection for the knee that if you get any lateral trauma to the knee, it has a bit of give to it. So imagine if we supported all of our weight on our elbow joint and something hit us from the side, okay, like that. It would break bone. The knee's a little bit flexible because it's a condyloid joint, and when there is lateral movement across the knee can give a little bit. Those cruciate ligaments are part of that support. Okay? They're soft tissue, so they have a little bit of give in them, but they're connecting the two bones together, essentially in that direction. Okay? Now, often these are referred to by their initials, so we have the ACL and the PCL. Have you heard of either of those before? Which have you heard of? Raise your hand if you heard of the ACL. Keep your hand up if you've heard of the ACL, which you just raised your hand for, and you've heard of the PCL. Put your hand down if you've never heard of the PCL. A lot fewer people have heard of PCLs before. So those of you that have heard of ACLs, how
In what context have you heard of them?
Had mine replaced
Why did you have it replaced?
because I planted, twisted, dislocated my kneecap and tore my ACL.
Usually it's because ACLs get torn. Now, actually, PCLs get torn also, but it's a much less likely to happen. It has to do with the direction of trauma. So you have your particular example. Somebody else, where have you heard reference to torn ACLs?
Sports.
Yes, common sports injury. And thinking about it as a sports injury is a great way to understand why ACL tears are much more common than PCL tears. ACL tears occur when there's a lateral blow to the knee. So the tibia and the femur are sitting like this. If you get lateral blow, then the anterior cruciate ligament is going to be stretched and it's going to tear. If you get a medial blow to the knee, then it's going to go the other direction and the stress will be put on the PCL. And it can tear if that happens. But it's far less likely for you to get a medial blow to the knee than a lateral blow to the knee. Why? Right. So as I'm standing right here, the lateral side, that's kind of redundant, lateral aspect of either knee is exposed, the medial aspect of either knee is protected by the other knee. So unless you're running like this and somebody clips you from inside, you're not likely to get a medial blow to the knee. So PCL tears are much less common than ACL tears. Now, as I've talked about this over the years, people have asked about other abbreviations. There are a number of other tendons and ligaments and all that sort of thing in there. And there are other types of injuries. I just like to point out the ACL and the PCL, mostly because the ACL tear is so common. There was a study that I read about a while back, probably about 10 or 12 years ago now, or actually a book I read describing some studies. Comparing, so the person that wrote the book is an orthopedist from Philadelphia. He had three main sets of clients. He worked at a medical school in Philadelphia, I can't remember which one, and as a prominent orthopedist, he consulted with a number of different client groups. One was the professional basketball team, which I guess is the 76ers in Philadelphia. And another was the Philadelphia Ballet Company, whatever they call themselves. And then also he dealt with sports injuries in college students with whatever college was associated with the medical school he taught at. So in his book, he described these three different groups of clients, basically talking about professional male athletes, professional female athletes, which is what you could consider a ballet dancer, and amateur athletes, which would be college athletes of other types. And in discussing this for the amateur athletes, he was really talking about the women's field hockey team at the college, which is a place where ACL is common. Of those three groups, which do you think is most likely to have ACL tears?
Amateur female.
Yeah, amateur female. And which do you think is least likely? That is
Professional male. Or just professional in general.
professional female. Now, part of that might be because ballet isn't the same kind of potentially contact sport that something else is. Not that basketball is supposed to be a contact sport, but there is quite a bit of contact and quite a bit of movement. But actually, from all of his patients, he saw that the professional female athletes, ballet dancers, were the least likely to have ACL tears. And so, really, the professional male athletes wasn't a big part of the story because he's really talking about professional versus amateur female athletes. But it was kind of interesting what he found, that the female athletes were the least likely to have ACL tears. Now, what he discovered from this, or how he explained this to happen, had to do with the difference between amateur and professional female athletes' willingness to do work with the musculature in their legs. Now, dancers, of course, have to have very muscular legs to do all the sorts of things they do. So they're certainly going to do all sorts of stuff.
He characterized the amateur female athletes that he was dealing with on the field hockey team as not willing to do the kind of leg work necessary to be as well protected against ACL tears as the professional dancers, because they were afraid of bulking up and making their legs more muscular or whatever. But he would repeatedly advise them to do that, because the real reason why the professional female athletes were most protected is because of all the work they did with their the musculature in their legs. They were strong enough to keep that kind of damage happening to the leg unless there's a really severe blow. So the dancer fell and landed weird on her leg, it could happen. But for the kind of trauma that she was actually exposed to in her leg was muscular enough to protect against that. But then the field hockey players weren't willing to do the kind of work to build up the musculature that would support the knee, and they were exposed to some pretty awful lateral trauma to the knee, so it's very common. And it was really just kind of a numbers game that actually the male athletes didn't see quite as much, but they're still going to do the same kind of work, building up the musculature that's going to help support the knee. And they were pretty well protected. It's just, it might have had something to do with the way that a ballet dancer trains, that she's able to support her knee better than an athlete that's used to running and jumping on a basketball court, something like that. I'm not quite sure. But the main take-home message from it was really, these soft tissues do a lot to protect the knee, but having proper musculature available to help out is an important step. I read this book, like I said, 10 or 12 years ago, and I had really bad knee pain at the time. I broke my leg when I was a kid, and it caused all sorts of problems. And from that book, it got me motivated to do some work. I did a lot more work at the gym and that sort of thing. And the knee pain basically went away because the musculature was able to sort of support the function of the knee joint, and it just didn't hurt anymore. And that was kind of the whole thesis of the book, was about, for older people, exercise is important because the musculature is really going to help support the skeleton as the skeleton and the joints age and that sort of thing. So that's my little public service announcement to go with that. But I did want to point out both the menisci and the cruciate ligaments, which are an important clinical aspects of the knee. And so I want to add that into talking about the joints. So, there's not really a great way to add this into what we're going to do next week. So I'm just going to mention this here because we're talking about joints and movement and that sort of thing. Muscles are attached to bones by tendons. And basically a tendon is anywhere that we have a connection from muscle tissue to bone tissue, from a muscle to a bone. It doesn't have to necessarily be tissue level, it could be organ level. And so in this picture here, they're pointing out tendons and that sort of thing. Now, another weird thing about the knee joint, not so much about it being the knee, but more about the idea of tendons. This connective tissue here that goes from the quadriceps muscle to the patella, this is called the tendon of the quadriceps femoris, which is that specific muscle there. The tendon actually continues on and attaches to the tibia there, but since the patella, a sesamoid bone, forms within that tendon, actually before birth, the tendon from the patella to the tibia is actually referred to as a ligament, because ligaments are bone-to-bone attachments. But really, functionally, the muscle here is attached to the bone here, and that's where movement takes place. Okay, make them a little bit larger. So that whole thing there is functionally the entire tendon. It happens to be some of it calcifies in the middle, and that's a bone. So from the patella on, the rest of it's called a ligament. I want to talk a little bit about attachments and muscles just it works a little bit better here than it will talking about stuff next week. There's actually two types of attachments. A cord-like attachment like we see here is called a tendon. A similar thing, but that's flat, is called an aponeurosis, and I'm not going to spell that out because you can look it up and it's not something we deal with a whole lot. But anywhere that there's flat connective tissue, like over the surface of the abdominal muscles or over the top of the head, it's really just a tendon-like a thing, but it's flat instead of round like a cord, so it has a technically different term. We're really only going to talk about tendons, just functionally, all of those things act like tendons. Structurally, tendons are cord-like and the other things are sheet-like, but we don't need to really worry too much about the structural differences. The other thing we want to consider with attachments, however, and whether this is a tendon or an aponeurosis, for a given muscle, there's going to be attachments at either end. Okay? And when we're talking about the attachment points for a muscle, one end is referred to as the origin, or where the muscle starts, and the other is called the insertion, or where the muscle attaches to the bone. What the muscle attaches to cause movement. Generally speaking, origin is the end of the muscle that attaches to the non-movable side, and the insertion attaches to the movable side. So if we think about the biceps brachii, which causes flexion of the elbow, the origin of the biceps brachii is up in the shoulder, which does not move when you're flexing your elbow. And the insertion is into the forearm, which is the part that moves when you flex your elbow. So that's a simple way of describing those two terms. I just put these. Okay, so those are the two terms I referred to earlier. Aponeurosis is singular, aponeuroses is plural. And then also for muscles, we talk about the origin and the insertion. The origin is to the less movable bone, and the insertion is into the more movable bone. We usually think of muscles in some of our major movements are in the arms and legs. For the arms and legs, origins are always going to be proximal, and insertions are always going to be distal. When you're moving part of your arm or your leg, you're moving the distal end away from or towards your body. The distal is moving relative to proximal. Now, there are situations where that's not necessarily the case. Okay? So if I'm going to bend my hip joint, I can move my leg, and obviously the distal end is moving relative to the fixed proximal end here. But I can also bend over at the waist, and I'm still making the same movement, but the less movable side, body core, is moving relative to the more movable side, which is the distal side. Origin and insertion is always the same for any given muscle. It's not a relative term. When we talk about a muscle, it has its origin and it has its insertion. If I'm flexing my elbow like I described, then I'm moving the insertion relative to the origin. And generally speaking, for a muscle, it's closer to. So as this muscle contracts, the insertion moves towards the origin. But there are situations, and keeping with the forearm, if I were to do push-ups, then my forearm's the fixed part and the rest of my body's moving. Okay? So in this situation, the origin is moving relative to the insertion. But that's an unusual situation. We don't change what we call the origin of the insertion. We just understand in that situation, things move a little different. When we talk about and learn about the muscles next week, you'll need to know for each muscle where its origin and where its insertion are. So with bones, you had a bunch of different bone markings to know about. What you need to know about the muscles is where they're attached. And what you'll find for a lot of them is where they're attached is one of the bone markings that you learn. For instance, the insertion of the deltoid muscle is this big one down your shoulder. Its insertion is into the deltoid tuberosity of the humerus. And so when this muscle contracts, it causes abduction of the arm, basically by pulling on that lateral surface of the bone. So that was one of the bone markings that you're responsible for, and it's really because it's an important attachment site for a muscle there. So a lot of the bone markings that were on the list of bones that you learned about last week are going to be things that are important to understand about where the muscles are attached. And the muscles are moving the bones. So they're moving insertions and origins relative to each other, usually insertion towards the origin, but there are some special cases there. So I want to talk about that here because it kind of fits better with the joint stuff that we're talking about. Next week, we'll learn about the muscles. It's a lot to do in a week, but then isn't everything this summer? So we'll move through that stuff kind of fast. Anything that you can do leading up to next week to be prepared for that, make sure you are familiar with the chapter to some degree walking in. That'll help us understand things a bit more. There are some videos I'm going to show you that explain some things better because movement's a very dynamic process, and showing you pictures on the screen from a book or something like that is not a very dynamic way to show it. So the book is going to explain things, but hopefully some things will gel a little bit more as I show you the animations to address it a bit better. So that's what I wanted to finish up with today, and I was able to wrap it up a little bit early so you can get out here and decompress from the trauma of this morning. So there are assignments for the joint chapter in there, mostly about the classification of joints and the types of movement. So that stuff's due for next week, and then next week we'll be getting into the muscle stuff. So have a nice week.